Welcome to the fourth installment in the Spring 2019 Trends in Behavioral Health webinar series. This series is a collaboration between Epstein Becker Green, Nelson Hardiman, and the Behavioral Health Association of Providers. Today's webinar is titled Office-Based Opioid Treatment, What You Need to Know. Before we begin the presentation, please note that today's webinar is being recorded and participant phone lines will be placed on mute throughout the program. You are welcome to submit questions directly to the presenters during and after the webinar. Their contact information will also be displayed at the end of the presentation for your reference. In 2 to 3 business days, Epstein Becker Green will email all registrants a link to an access code of the recording of today's program and PowerPoint materials. I'm pleased to welcome and turn to today's presenters, David Shillcutt, an associate in Epstein Becker Green's Healthcare and Life Sciences practice, and Kristina Sherry, an attorney at Nelson Hardiman in the Transactional and Compliance Practice Groups. Kristina, you can proceed.
We're also representing BHAP, the Behavioral Health Association of Providers, which is a national trade membership association that provides education and advocacy for behavioral health care providers and related entities. Membership in BHAP provides confidence that providers are informed about compliance with changing legal regulations and industry best practices while reinforcing provider reputation within a network of ethical business practitioners. BHAP's educational and certification opportunities, such as this webinar, in cooperation with Epstein Becker, and its certificate in addiction treatment marketing, build skills with higher level learning designed for providers interested in ethical business practices and regulatory compliance, and informing prospective consumers of the dedication the provider exhibits toward honest business practices. Lastly, BHAP's advocacy efforts encourage industry involvement and self-regulation by informing providers of legislative activity that will promote state and federal rules and regulations that benefit providers and those suffering from behavioral health illnesses. For more information about BHAP, you can visit its website at www.bhap.us. And now David will get us started.
Thanks, Kristina. Next slide. So today we'll start by talking about the policy and clinical context. Next, I'll pass it to Kristina to talk about the legislative context. Then I'll talk about models for delivery of office-based opioid treatment. Kristina will talk about OBOT in California. We'll both talk some about regulatory and policy risks and opportunities, and we'll close with some Q&A. Next slide, please. So starting with the policy and clinical context, next slide, please. So I wanted to start by showing where opioid treatment services fit into the full spectrum of an appropriate continuum of care. This graphic shows the levels of care for addiction treatment as defined by the American Society for Addiction Medicine, or ASAM. And you can see that the services we'll be talking about today are level 1 services, which are for patients who are medically stable, they have supportive recovery environment, and they're willing and ready to engage in treatment for an opioid use disorder. I wanted to use this graphic just to remind folks that office-based opioid treatment providers and opioid treatment programs, or OTPs, are just one part of an appropriate continuum of care. And it's important to think about this continuum as a system rather than a collection of independent providers, and ensure that we're accounting for things like how patients enter the system, whether it's via an emergency department or a referral from primary care following screening and brief intervention or some other way, and be thinking about how patient care is managed and coordinated as they move among different levels of care as their situation and treatment needs evolve. All too often, I'll point out that patients are expected to kind of ping pong between inpatient detox and outpatient services, or maybe no services at all, without a lot of access to the intermediate services and shepherding between levels of care that are so important. And then, of course, we wonder why attrition rates are so high. Next slide, please. So the evidence base for medication-assisted treatment, or MAT, is strong. Patients who take one of these medications are half as likely to die from their addiction. They're more likely to stay in treatment and have better long-term health outcomes. MAT is really important, and we really need to be thinking about how we can expand access to MAT. Although it's generally accepted to work best in combination with behavioral therapies, which include things like contingency management or cognitive behavioral approaches or other forms of counseling, the evidence shows that MAT alone is more effective than behavioral treatment alone. So if you're just getting one, let's get the MAT, and counseling is helpful and important, but it's really important to start by focusing on how we can get people into medication-assisted treatment. As a side note, briefly, I'll note that I'm using the term MAT in this presentation, given that that's the most common term in the field to refer to pharmacotherapy for substance use disorders. But a recent Institute of Medicine report, the authors chose to instead use the term medication-based treatment for opioid use disorders instead of medication-assisted. They said they use this medication-based treatment term to highlight that medications are the first-line treatment for opioid use disorders as an integral part of their long-term treatment plan. And they're not just complementary or temporary aids on the path to recovery. They really are the foundation of treatment for substance use disorders. Unfortunately, nationwide, fewer than 20% of the around 2 million people who are struggling with opioid addiction in the United States are being treated with the medications that are most likely to nudge them into remission or prevent them from overdosing. Access varies really significantly by state. So, for example, in West Virginia, I read that around 75% of Medicaid enrollees with a substance use disorder are getting, or an opioid use disorder, are getting prescribed MAT. But access is really severely limited in many parts of the country, especially in rural areas. Coverage also varies by payer, and although every state Medicaid program covers at least one MAT drug, many, I think even most, do not cover all three. And many states and payers have limits on coverage that do not comply with national guidelines or with mental health and substance use disorder parity laws, which I'll talk about a little bit more at the end of the presentation. Unfortunately, the widespread persistence of treatment settings that ban or discourage medication-assisted treatment continues despite the lack of evidence for this approach and the potential for harmful effects. Many funding streams steer patients to these abstinence-only facilities, especially through the criminal justice system or housing authorities, which often prevent participants from using these medications. Yet relapse or return to use rates following detox or medically supervised withdrawal are as high as 65 to 90%, depending on the study. And abstinence-only approaches are dangerous, as it carries a higher risk of overdose due to a reduced tolerance for opioids when patients, if and when patients return to use. And just as a side note, I'll note that relapse rates for MAT are comparable to adherence to treatment rates for many other chronic conditions. Although I think Kristina will be talking more about stigma. Next slide. So I stole this graphic from the Institute of Medicine report that I just mentioned. I think it's really helpful, the next two slides as well. This shows the availability of SUD treatment facilities of any kind in the U.S. Next slide, please. This shows the SUD facilities offering any form of MAT, methadone, buprenorphine, or naltrexone. So that's about a third of the facilities that you saw on the previous slide. And next slide, please. And this is a graphic of the SUD facilities in the U.S. offering all three MAT drugs. Only around 6% of SUD providers offer all three MAT medications. We'll talk a bit more about some of the reasons why there's so few providers that both dispense methadone and prescribe buprenorphine, but it's important to keep in mind that no one treatment is appropriate for all patients, and that true patient-centered care and appropriate application of medical necessity standards really dictate that a range of treatments be available to match the individual patient's needs. So again, I want to acknowledge there's important structural reasons why many providers don't offer all three forms of treatment, but that doesn't diminish the fact that this represents a significant barrier to access to appropriate treatment. Ohima, can you quickly toggle back through the previous two slides and back again? Just want to highlight how that worked. That's all. Next, this offers at least one form, and finally, the ones that offer all three. Next slide, please. All right, so this slide shows the main three forms of medication-assisted treatment: methadone, buprenorphine in combination with naloxone, trade name Suboxone, and naltrexone, trade name Vivitrol. All three of these are effective in reducing cravings and severing the ties between opioid use and situational or emotional triggers that define addiction. So they are all effective, but there's important trade-offs among them. Methadone is an opioid agonist, which means that it has an effect similar to other opioids by increasing the effect of a certain type of neurotransmitter called a mu receptor. So as an opioid, like most opioids, it can also be prescribed to treat pain, and it can cause euphoria in certain doses. As an opioid, it helps to diminish and manage withdrawal. It has a much longer half-life than other opioids, and so it's really helpful as a treatment. Stays in your system longer. But it also has a higher risk of abuse and physical dependency relative to other forms of medication-assisted treatment, and can cause dangerous interactions with other medications or with alcohol and other drugs. It's dirt cheap, but due to the risk for abuse, it can generally only be dispensed in a methadone clinic, also known as an opioid treatment program, or OTP. Unfortunately, obviously, daily trips to the methadone clinic are hugely disruptive to patients' lives. So although it's a highly effective form of treatment, especially for at-risk patients who can benefit from this really highly structured treatment environment, program attrition rates tend to be high since the methadone clinic is rarely located in a location that's convenient for the patient. And getting to and from the clinic can obviously pose significant challenges for employment and family responsibilities, et cetera. Buprenorphine, I'll mostly just say buprenorphine during this presentation, but I'm referring to bup in combination with naloxone, such as a brand as Suboxone. The buprenorphine itself is a partial opioid agonist, meaning that it has some of the risks of methadone, but it's a partial agonist. It's generally administered sublingually under your tongue in the form of a tablet or film that dissolves under your tongue. The addition of naloxone, which is an opioid antagonist, and so like as an antagonist can be used as a standalone drug to reverse overdoses by essentially kicking off the opioid medication from the neurotransmitter. So adding naloxone to buprenorphine reduces the potential for abuse. The naloxone isn't readily absorbed under the tongue, but if you try to snort it or inject it, then it'll offset the agonist properties of the buprenorphine. So this lowered risk for abuse makes it possible to fill weekly or monthly take-home prescriptions, which is an obvious advantage. And when you combine that with the lowered risk for overdose, makes it really the preferred form of treatment for many patients. Finally, naltrexone is a competitive opioid antagonist, so similar to the naloxone. It blocks up the mu receptor, but doesn't activate it. As an antagonist, it can't be used until after the patient is opioid-free, so finished with withdrawal, all the opioids are out of your system, since otherwise it could cause a sudden and dangerous withdrawal. It also doesn't provide the pain relief that methadone and buprenorphine offer as agonists or partial agonists. And that's really important given that people with opioid addictions often experience chronic pain, either due to the physical condition that got them prescribed opioids in the first place and led them to addiction, or due to the fact that your nervous system essentially gets rewired through the prolonged use of opioids and can cause really intense bone pain and other symptoms as your body learns to live without the opioid. This is a big reason why patients rarely choose naloxone when given a choice of MAT therapies. In fact, low rates of patient adherence to treatment for naltrexone have made it research assessments of its clinical efficacy difficult, so the evidence is not as strong as for bup and methadone. However, like other forms of MAT, the studies do tend to demonstrate that patients who remain off opioids longer were those who took the MAT drug longer. Quickly, I'll note that disulfiram and acamprosate are also used to treat alcohol use disorder, And so you may hear it in the conversation around SUD treatment, especially given that opioid use disorder has really high rates of comorbidity with alcoholism. As I mentioned, naloxone, trade name Narcan, is used to treat opioid overdoses, and it's also prescribed or made available to opioid users, as well as family and friends, first responders, and related individuals and organizations. And so naloxone is obviously also an incredibly important part of keeping people alive when they have an opioid use disorder during the acute phases of their disorder. Next slide, please. In a perfect world, providers would offer both methadone and buprenorphine, but both are controlled substances under federal law, and there's heavy regulatory requirements for both. OTPs, or methadone clinics, have to be certified by SAMHSA and registered by the DEA. So, and before certification, they have to get accredited by an organization like Joint Commission or CARF, and then SAMHSA certification and DEA registration. It's a pretty intensive, burdensome process. The OTP registration with the DEA also has to be renewed on an annual basis. Kristina is going to talk a little bit more, I think, about the process for physicians to get waivered to provide buprenorphine, but I'll just mention that there are specific training and registration processes involved for bup as well, in order for a physician to be able to prescribe medications with Suboxone or other medications with buprenorphine. A couple of other quick notes on this slide. First, methadone is not approved by the FDA to treat people under 18, and buprenorphine is only available starting at 16 years old. So that's one advantage for buprenorphine, but unfortunately, younger adolescents are often treated with abstinence-only approaches or sometimes with naltrexone. I'll also note that the counseling and behavioral services that I mentioned are required for methadone treatment under OTP licensure requirements, but physicians prescribing buprenorphine just have to ensure that those services are available. I'll talk a little bit more at the end of the presentation about how payers sometimes make those services a condition for treatment or for reimbursement, but those are payer requirements and not federally mandated. Next slide, please. So as I've mentioned, there's a variety of reasons why methadone clinics are unsuited to a lot of patients' needs and preferences, and that's a big part of the reason why fewer than 20% of opioid-dependent persons are getting treatment in traditional treatment settings. First, as we saw on the map, there just aren't that many OTPs in the country, and certainly most of them aren't located in places that are easy or convenient for patients to travel to on a daily basis. There's a lot of stigma associated with them, given like they're in rough parts of town, and you have to explain to employers and family where you're going all the time and why you're going there. Given the heavy restrictions on the actual dispensing, it's not a friendly, warm environment where you got people who are standing guard over you to make sure that you are swallowing the medication, and you're going through the assembly line. There's high staff turnover in these often at these types of clinics, and so it's hard to develop strong patient-provider relationships. So one of the biggest advantages for OBOT treatment for buprenorphine is that it's not a methadone clinic. But it's also important to recognize that SUD treatment in an office-based setting is much easier to integrate with physical and mental health care, which is a really huge part of treatment efficacy. You can co-locate the providers or even be the same providers. And this is really important given the high rates of comorbidity of physical and mental health conditions with opioid use disorders. And it's extremely important to the success of the SUD treatment that the physical and mental health needs are also getting met. Obviously, effective integration of addiction treatment with physical and mental health care is also important because unmet addiction needs tend to complicate the physical health and mental health treatment needs. So if you're not getting your addiction treated, then you're going to have trouble with your physical and mental health conditions. And of course, unmet treatment needs and siloed care tend to significantly increase the preventable mortality and healthcare costs. So integration is the drumbeat these days, and OBOTs are a really important way that we can do that. Kristina, you want to talk about the legislative context?
Sure. Thanks, David. Can go to the next slide. And then the next one. This section will provide some context, legislative context about how we got where we are today with a lot of recent activities in the past few years, both federally and in California, which I'll talk about at the end of this section. But a very important piece of federal legislation that's still referenced heavily today because of the waivers that we'll discuss is the Drug Addiction Treatment Act of 2000, or DATA 2000, and that's probably best known for introducing the possibility of DEA waivers for office-based prescribing and dispensing for opioid use disorders. And the reason the waivers were needed is because some medications used in MAT, or MBT, I'll call it MAT throughout this section, are controlled substances governed by the CSA, and the DATA 2000 Act permits physicians who meet certain qualifications, which we'll discuss a little later, to treat opioid dependency with narcotic medications approved by the FDA, including buprenorphine, in treatment settings other than OTPs. And the earlier framework before this was found under the Narcotic Addict Treatment Act of 1974, which had required separate annual registration for dispensing narcotic drugs for maintenance treatment or detox treatment. So the DATA 2000 allowed qualified physicians to take the waiver from this separate registration requirement under that 1974 Act. And under this Act, they could get initial authorization to treat 30 patients, and then after a year could apply to treat up to 100. And that was with a, based on approved addiction certification or taking an 8-hour course. So they generally had to hold a subspecialty in addiction psychiatry. Okay, we can go to the next slide. So even more recent legislation has expanded this waiver effort. The first act we'll discuss is CARA, the Comprehensive Addiction Recovery Act, which was the first major federal addiction legislation in 40 years. It took kind of a multi-pronged approach and focused on prevention, treatment, recovery, law enforcement, and overdose reversal. But one important aspect of that was that it increased the it increased that limit to 100. And I should clarify this slide. The increase to 275 actually came from a SAMHSA final rule to increase the limit up to 275. But the CARA also added to the criteria for who could be a qualifying practitioner for this waiver, and it added nurse practitioners and physician assistants along with physicians, and it would allow them until 2021 to apply for that waiver. And it required 24-hour training. It's not clear how that number was reached. It's not clear why it was 3 times what's required for physicians, but they can meet that, receive that waiver with 24 hours of training. And it required the ability to refer for behavioral treatment. But speaking to the increase to 275 patients, there was a recent study published in last September, that kind of found that buprenorphine remains underutilized even amid this expansion for how many patients the physicians and now the mid-level practitioners could treat. The study surveyed clinicians who had obtained the initial federal data waiver, and it found only that about 13% were prescribing at or near their patient limit within the past month. And there were several reasons given for this kind of not prescribing up to the limit, which some of those reasons included insurance reimbursement issues and just constraints of the practice. So even more recently was the Federal Support Act, signed into law by President Trump in October, and that stands for the Substance Use Disorder Prevention that promotes opioid recovery and treatment, or Support Act. And this, again, was pretty broad, but with respect to MAT, it codified the increase into 275. So in 2016, that 275 limit had come from the final rule, from a rule, but this support codified that upper limit, and it made permanent the prescribing by nurse practitioners and physician assistants, rather than just that 5-year pilot. And it further expanded authorization for additional practitioner types, which I'll get to in a few slides. So we can go to the next slide. So a very significant portion of the Support Act was the expansion of Medicare coverage. Starting in, historically, opioid treatment providers weren't recognized as Medicare providers, meaning that beneficiaries receiving MAT at opioid treatment programs had to pay out of pocket. But starting in 2020, treatment for opioid use disorders may receive a bundled payment for OUD treatment services furnished to an individual during an episode of care. And this could be implemented through one or more bundles based on maybe the type of medication provided, frequency of services, scope of services furnished, or other factors. It also included some Medicaid expansion, which we'll address later. So we can go to the next slide. So Section 3201 from the Support Act, as we alluded to earlier, makes permanent the authorization for those mid-level providers to get that waiver. It codified the upper limit of 275 patients, and it further expanded the provider types who could obtain the waiver to now include clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives. And those additional provider types can get that waiver for up to 5 years. You'll see at the bottom of this slide, no later than 2 years after support was enacted back in October, HHS will submit to Congress a report that assesses the care provided by physicians treating more than 100 patients or the mid-levels treating 30 or more. And the report will include recommendations on future applicable patient numbers, considering things like average frequency with which the practitioners see the patients, frequency with which the patients receive counseling, frequency of toxicology testing, average monthly patient caseload for each practitioner. So that study, within the next few years, will look at those things. The next slide also expanded this waiver to physicians who've graduated from allopathic or osteopathic medicine medical schools. And I don't think this is not on the slide, but the section also states that HHS will consider ways to ensure that an adequate number of qualified practitioners who have a specialty in pediatrics or the treatment of children or adolescents are also granted a waiver to treat children and adolescents with substance use disorders. So the next slide addresses funding under some of these recent pieces of federal legislation. Under CARA, CARA didn't appropriate funding for opioid overdose prevention, but it authorized a total of $181 million in new funding for programs designed to reduce the impact of opioid use disorders. And separately, the 21st Century Federal Cures Act did appropriate funding, and which is $5 million per year in 2017 and 18. That money was to be distributed across all 50 states to address the opioid abuse crisis. And in awarding the grants, the HHS may give preference to states with a higher incidence or prevalence of opioid use disorders. So we can go to the next slide. And in California last year, I think it was said that more than 20 bills addressing the opioid crisis were introduced, and more than the majority of these passed. Some highlights here. AB 349, the Department of Healthcare Services in California will adopt new regulations by 2020 to update reimbursement rates for the drug Medi-Cal treatment program. SB 992, the primary purpose of the bill was to require licensed and certified addiction treatment facilities to disclose their ownership interests. But another facet of this bill was to prohibit denying placement on the basis of someone having a valid prescription for narcotic replacement treatment or MAT. And later we'll discuss a federal case that kind of addresses turning away or discriminating against people with these prescriptions. And then finally, not specific, but SB 1228 broadly prohibited patient brokering. And it's very broadly worded, but it seeks to address specifically the addiction treatment industry, and it prohibits giving or receiving anything of value to endorse a referral seeking substance abuse disorder services. And this affects the facility, the owner, a 10% or more owner of such facility, or anyone employed by it. It just broadly prohibits kickbacks and referrals, so it's the patient brokering law to be aware of in California. And later, and when we discuss telehealth at the end, we'll talk about another bill that expanded telehealth reimbursement. Okay, I think I'll pass it back to David.
Thanks, Kristina. Next slide, please. So I'm going to talk through a few state models for how office-based opioid treatment is getting delivered and funded. A few common themes that you'll see. There's a variety of models for ways to integrate medication-assisted treatment into primary care that can be adapted across really diverse healthcare settings. However, in any model, some of the key components include provider and community education, including continual medical education activities, community-based advertising campaigns, and stakeholder conferences. Coordination and integration of OUD treatment with other medical and mental health needs is obviously really important, including SBIRT, that's screening, brief intervention, and referral to treatment in primary care, and integration of primary care and OBOT or community mental health centers, but also integration and coordination among addiction treatment providers at different levels of care. So coordination and integration, and finally integrated or coordinated with behavioral and social services. A wide variety of staffing plans and structural partnerships can be used, but successful models will adapt to local and regional resources and build on existing strengths and partnerships. Models will also have to develop funding strategies that are adapted to state requirements and payer coverage. For example, thinking about how to reimburse for functions like the nurse care manager role or whatever staff member is providing the care management function, and how you're going to fund the services to connect patients to social and support services that are, of course, integral to effective treatment. Next slide, please. So Vermont pioneered the hub and spoke model. In this model, the hubs are OTPs that are available to serve patients with more acute or complex needs. They serve as a nexus for coordination of both treatment and technical assistance and administrative type functions. They're supported by spoke providers that provide MAT for more stable patients with less complex needs. Psychosocial services are embedded within the spokes, including social workers, counselors, and community health teams. Patients transfer between the hub and a spoke on the basis of their changing care needs, and those transitions are coordinated by a nurse or care manager. Medicaid coverage in the Vermont model is financed under the Health Homes Authority. So these SCD health homes offer the 6 core services that are required under the health homes model. Those are comprehensive care management, care coordination, health promotion, comprehensive transitional care and follow-up, individual and family support, and referral to community and social services. These core health home services are generally reimbursed on a per member per month basis, And then the state supplements that with block grant dollars from the SAMHSA block grant to fund data waiver training for physician prescribers. And the state also provides funding for behavioral health specialists to provide counseling and related services in the hubs. Some important advantages of this model include the availability of tiered care and integration with primary care with the regional OUD management expertise. The use of care coordinators is really important, and embedded psychosocial services at the spoke sites. Some of the challenges include the lack of availability of OTP hubs in all settings that wish to implement MAT, so around the state. Again, there just aren't enough OTPs to go around. Key factors for sustainability that have been found for this model include contracting and coordination with public and commercial payers, flexibility on program requirements, for example, the ability of providers to adjust staffing ratios in response to patient needs, adequacy of health home reimbursement to hire, train, and retain competent staff, depending on how that health home PMPM gets set. And finally, implementation support from the state or payer is extremely important. Next slide, please. In Maryland, there's the Baltimore Buprenorphine Initiative. This starts with a centralized initial intake in an OTP where the patient gets a buprenorphine prescription and induction, as well as any treatment needed to stabilize their condition. A caseworker is involved from the start to help with health insurance, like helping with prior authorizations and such, picking a managed care plan, and a primary care provider that's going to meet their needs, and planning, coordinating, and tracking transitions of care. Once the patient meets the transfer criteria, they transfer to primary care to receive MAT, but the OTP continues to provide ongoing counseling and behavioral services, as well as care management for at least 6 months. So this ongoing role for the OTP, a little different from Vermont, means that geographic proximity is really important in this model, which of course makes sense in a place like the Baltimore area, but requires some more tweaking for a rural area. You know, you might have to consider some telehealth or related strategies to provide those support services. One contrast with the Maryland and Vermont models, or between the Maryland and Vermont models, is that participation from both patients and OTPs is on a opt-in rather than opt-out basis. So that's led to lower participation rates in Maryland, both from patients and OTPs. On the other hand, at an administrative level, one of the real strengths of this initiative is the collaboration of multiple governmental and quasi-governmental agencies that they have in Baltimore County that have created a really strong financial and programmatic model. Next slide, please. In Massachusetts, they developed what they call the collaborative care model. This is not the same thing as the American Psychiatric Association's collaborative care model, which is for primary health, mental health treatment and primary care. There's certainly some similarities there, but you may see references to the evidence base for the collaborative care model, and that's generally speaking to the mental health integration strategy. In any case, the Massachusetts model is a little bit like the inverse of the Vermont model, in that the Massachusetts model is built around the nurse care manager role, who would be a spoke in the Vermont model. The nurse care managers perform screening, intake, and education of patients. They coordinate with the physician for the MAT prescribing, and the physician, of course, oversees dosage and will sign off on the diagnosis and those types of physician credential functions. But the nurse is really the hub of it. They do the screening, the intake, and education of patients. As I said, they collaborate with the pharmacist for refills and medication management and the physician. It's delivered, the MAT in this model is delivered in an FQHC, a federally qualified health center, or a community health center. But they have expedited referrals to OTPs as needed for patients who need a higher level of care. And then the psychosocial and support services, they may be integrated on site or at worst somewhere nearby. This model was designed with a focus on increasing patient access. It achieves this by providing a variety of things. There's a big focus on support for, obviously, the intensive SED treatment needs, but they provide urgent drop-in hours, frequent follow-ups. There's a lot of planning around context-specific needs like pregnancy, acute pain, surgery, or injury to meet patients where they are. Other key components include staff support to address positive drug screenings or insurance issues, prescription pharmacy issues, and social supports, including assistance with legal or social issues, safety, personal safety, housing, and that sort of thing. They provide case management and patient navigation, program support, but they also provide program support for providers to help them manage large caseloads. The state does a lot to promote and support the program, including by providing training and technical assistance to participating providers. Before I pass back to Kristina, I just want to mention briefly a couple of other important models and programs to keep in mind. First, Project ECHO, that stands for Extension for Community Healthcare Outcomes, links primary care providers delivering MAT, often in rural areas, with a health system using an internet-based interface for mentoring and education. It emphasizes nurse practitioner and physician assistant-based screening with referral to the collaborating physician before initiation of MAT and for ongoing treatment. Counseling and behavioral therapies are provided by the ECHO team member during weekly teleconferences. And like other models that we've talked about, patients with complex needs are referred to an OTP. So there's really strong evidence for Project ECHO. It's a really promising model. And then finally, this is slightly outside the scope of the presentation, but I just wanted to take a minute to call out a few examples of sort of non-traditional treatment settings beyond the standard OBOT and OTP settings that can be really impactful in expanding access to these super important MAT services. So some innovative settings that have been successful or at least show promise include mobile medication units that provide MAT directly to people in their home or community, group-based treatment for homeless individuals, treatment and syringe or needle exchange programs. There's some physician-pharmacist collaborative models, and low-threshold, quote, transition clinics or methadone linkage programs for people who are recently released from jail or prison. Just given the incredibly low rates at which people with opioid addictions are actually getting treatment in this country, it's really important that we start thinking harder, I think, about how we can develop health systems that can reach people where they are, both physically and metaphorically. So while we certainly need to work hard to expand the proven success of the OBOT model, which we're focusing on today, I just wanted to flag that it's important to also be thinking about how we can incorporate some of these more innovative treatment settings and models into our health systems. So, Kristina?
Okay, so addressing California specifically, one a unique approach worth mentioning under California's Medicaid or Medi-Cal program is the drug Medi-Cal organized delivery system. And this is a demonstration project to expand access to substance use, access for people with substance use disorders through a Medicaid waiver. And again, it's meant to provide a continuum of services similar to the ASAM continuum of care. And counties that do counties that opt into this program have to provide this continuum of services. And those would include early intervention, outpatient services, intensive outpatient services, short-term residential, withdrawal management, opioid and narcotic treatment program services, and recovery services. And again, counties that opt in have to use an ASAM model and criteria and specify their standards for quality and access and coordinate with physical and mental health services, among other requirements. The next slide, David mentioned the Vermont hub and spoke model, and they sort of pioneered this approach, and California has chosen to adopt it through a 2-year SAMHSA-funded state targeted response opioid grant program. California's DHCS, or Department of Healthcare Services, has awarded about 19 hubs across the state to partner with community health providers to expand access. And under California's model, again, pretty similar to Vermont. The hubs would be generally narcotic treatment programs or medication units who serve as regional consultants, and they're tasked with working closely with the spokes to support prescribers and build capacity. And the spokes would be, a DATA 2000 waivered providers who prescribe and or administer buprenorphine. They could be a federally qualified healthcare center, mental health center, and the spokes receive a variety of support services from the hub, as I mentioned. So for medication-assisted treatment, the hubs may provide methadone, buprenorphine, and other approved medications. And then the spokes could, again, be those data waivered physicians and provide buprenorphine or other FDA-approved medications. And the focus regions under this program are, make sense, counties with the high overdose rates. Some of these are listed on this slide. And then the focus populations include American Indians and Alaska Natives, which some studies have shown are affected at a rate double other populations, perinatal clients, service members and veterans, and then youth, as well as the uninsured and underinsured. And moving to the next slide, we've talked a little about the requirements for getting that data waiver to prescribe. This is different. David mentioned the requirements for OTPs, which have to be registered and certified by the DEA and renewed annually. The waiver process is less burdensome, but one obstacle, as I mentioned, the studies showing that a lot of the providers, even if they have the waiver to treat 100 or up to 275 patients at this point, are underprescribing in relation to what they're able to. One estimate found that 30% of buprenorphine waivered physicians were actually prescribing medication, and less than 50% had elected to be listed on SAMHSA's physician and treatment locator site. And one study estimated that even if all waivered providers were prescribing at capacity, treatment coverage would still be inadequate for opioid use disorder. In fact, and I think the same study showed just under half of all persons suffering would receive treatment if all waivered physicians were prescribing at their capacity. And again, some barriers to this are worries about diversion, not enough time. Some feel their providers are unfairly scrutinized by the DEA with the waivers. And again, perhaps stigma, which we'll talk about in a few slides. Okay, we can move along to the next slide. One opportunity under some of the recent legislation that's passed, but especially in the past few years, is with telemedicine. And generally, under a 2000 law, the Ryan-Haight Online Pharmacy Consumer Protection Act, that was created to regulate online prescriptions and kind of rogue online pharmacies. And it imposed the requirement that a practitioner issuing a prescription for a controlled substance had to conduct an in-person medical evaluation with some exemptions. But recent legislation and guidance from the DEA and HHS has suggested that the data waivered physicians can be exempt from this requirement if practicing telemedicine as defined in the Act. And reimbursement for telemedicine has also been expanded in some of the recent legislation. The Support Act allows providers to be reimbursed for providing eligible sub-services to Medicare beneficiaries in their homes via telehealth at the same rate as in-person services. And another piece of recent California legislation expanded Medicaid reimbursement for individual counseling services delivered by telehealth. And we can go to the next slide. As I mentioned, one obstacle to expanding that comes in the form of stigma. Sometimes this is seen among the abstinence community. You know, medication-assisted treatment may be seen as replacing one addiction for another or substituting one opioid for another. You know, the belief that you're not really clean and sober if you're taking medication prescribed by a doctor. And this, you know, this is a treatment, it's seen as a barrier to the use of some of these medication-assisted treatments. The American Society for Addiction Medicine, you know, notes that it's even a violation of the Alcoholics Anonymous policies to offer medical advice to someone else in the community, or an AA member should not play doctor, it said. And they note that, you know, there's a benefit for these medication-assisted treatments. A recent case with the Department of Justice, and this is summarized on this slide, in January of this year, the Department of Justice reached a settlement agreement with a privately owned medical facility in Virginia. Seller Medical Associates was the name of the case. And this, the ruling resulted from a complaint under Title III of the ADA, Americans with Disabilities Act, that this medical practice refused to accept a prospective new patient for an appointment because he was prescribed Suboxone to treat an opioid use disorder. And the DOJ investigated and concluded that this practice also turned away prospective new patients who were lawfully taking controlled substances to treat their medical conditions, including opioid use disorders. So under this agreement reached in January, this medical practice, Selma, is not allowed to deny services on the basis of disability, including opioid use disorders, and they can't apply standards or criteria that screen such patients out. And under this agreement, they also had to adopt non-discrimination policies, train their staff on non-discrimination obligations, and report on their compliance. And they had to pay a fine. They had to pay like $30,000 in damages to the complainant, the patient who was seeking medical care there, and $10,000 in civil penalties to the United States. So that's a recent case worth agreement from the DOJ worth noting. And I'll pass it back to David.
Thanks. Next slide. So I want to leave a few minutes for questions, so I'm going to get right to the point on this slide. There are a lot of dosage limits and durational limits getting applied to MAT. As someone who led the drafting of the mental health and substance use disorder parity regulations in Medicaid and led the implementation of those requirements, I have a lot of opinions about these limits and would be happy to discuss them with you. In a nutshell, they often deviate from national standards, and there's generally not a good rationale for that. A lot of payers and even medical professionals believe that these medications should only be used temporarily to wean patients off of the stronger opioid. But there's strong evidence that retention on medication, on MAT for the long term, is associated with improved outcomes, and that discontinuing the MAT leads to relapse and overdose. So like relapse rates, as I said, are comparable to other chronic conditions. There are a lot of parity violations out there. Next slide. Drug diversion, again, I'm just going to speak really briefly. This is often cited as a reason not to prescribe MAT or to have these burdensome regulatory requirements through data waiver. I mean, even they increased the limit, but that's not the issue. It's, you know, like we're putting all these barriers in the way of making MAT available to folks. Drug diversion is a commonly cited one, but the risk for abuse is low. Diversion rates are lower than antibiotics and allergy medications, and the answer is not to restrict access. The answer is to make more access available. People are using buprenorphine in the street to treat their addiction. They're not using Suboxone, the naloxone combination, to get high. They're doing it because they don't have access to an actual healthcare provider. So let's find ways to make these more available, not less. So thanks to everyone for listening to us drone on. We have a few minutes for questions. So as we're waiting, Kristina, I've been wondering if you've seen any similar cases to the one that you mentioned, or if you know anything about the follow-up to that. Can you speak to the impact of or the takeaways from that ADA case? We may have a connection issue there.
Oh, sorry. Can you hear me now?
Yeah.
Okay, sorry about that. Well, this DOJ agreement was so recent. It was January of this year. I'm not aware of any similar ones yet, but, you know, I mentioned that California legislation from last year that explicitly prohibited discriminating on the, you know, specific to to licensed treatment facilities, but specifically prohibited discriminating someone on the basis of having this prescription. So it suggests, you know, protection, you know, people with these prescriptions may be protected under disability discrimination laws. But we'll keep an eye out for further cases like this.
So there is a question about if the DEA has published their mobile methadone updates. I actually am not sure about that, but I will check into that and provide some information. Well, if there are no further questions, I would like to thank everyone for joining us today. As I mentioned, we are available for any follow-up questions that you may have. We really appreciate your time and your focus on this really important area, and we hope to hear from you.
Thank you, David. This concludes today's webinar. Again, if you have any questions, please email the speakers directly. As a reminder, in 2 to 3 business days, Epstein, Becker, and Green will email registrants a link to access a recording of the presentation and PowerPoint materials. Thank you for attending.